Good afternoon. My name is Hope Frost and I'm pleased to welcome you to this Diabetes Virtual Consulting with Blood Glucose Data webinar. On behalf of the team at SBK Healthcare, I just want to say how proud we are to have produced this event, and we do hope that you find it useful. I would also like to thank Matrix for their kind support of this live webinar. I am now pleased to introduce to you your webinar leader, Dr. Iain Cranston.
Welcome to my office in Queen Alexandra Hospital, Portsmouth. The fact that we are on this webinar today means that actually everybody attending this webinar will also be able to undertake virtual consults. And I think virtual consulting is something that we've spoken about for quite a long time in diabetes. But haven't necessarily really got to grips with undertaking it as effectively as we might. And so what I'd like to do over the course of the next few minutes is to talk about, the process of doing virtual consultations and to make some general comments about that and some COVID specific comments. And then to talk more specifically about how we use data within those, because of course with chronic disease management we've spoken about virtual consulting now for the best part of 5 to 10 years. For most of us, however, it hasn't become a reality until the last 2 to 3 weeks. I share with you that frustration, although I have been doing modified virtual consulting for some time as sort of email consults. And so what I'd like to do, without further ado, is to move forward into the first of those processes. And of course, we've received a lot of input from, this happens to be a page from a recent BMJ article about virtual consulting in primary care, specifically for people who may have COVID symptoms. And I think a lot of this holds true for any form of virtual consultation. And I think that the key elements around virtual consultation are being clear what it is you're trying to do before you start, and making sure that you're prepared before you start. Checking that your equipment at your end works, and when you first start the consultation, that the person at the other end can still hear you and hopefully you can see them. In terms of the assessments that we'll make in chronic disease, those may be different than the assessments that we make for COVID, although I think in present times, obviously we also want to make that quick assessment around, are there any obvious COVID symptoms that the individual has whilst we're talking to them? Because obviously if we're trying to talk about long-term control and they're worried about their next breath, that's probably not going to be an entirely effective consultation. So we need to use some common sense, I think, in that respect. And of course, we've been given by the London Clinical Network a fairly clear view of what types of consultations would lend themselves well to virtual consulting. And if I concentrate on that group a little bit more closely, we know that potentially the following up people early on in their diagnosis of type 1 diabetes to give confidence and support around insulin use and insulin dose titrations, to help with those who we might consider as vulnerable patients, either people who've been recently in hospital and discharged, or who have problems with hyperglycemic episodes, or have particularly poor overall glucose control, or to offer intensive follow-up in those in higher risk situations. And the obvious one we've been talking about in that respect over the course of the last month or two has been pregnancy. We know that potentially any appointment that's face-to-face carries risk both for the person involved and for the person undertaking the appointment. And therefore, my own view of this, I think, is actually we can extend that process really of what's appropriate for virtual consultation in the context of where we are with COVID now. So, realistically, all we actually need to undertake a virtual consultation is a connection to the internet, a clear plan in our own minds what it is we're trying to achieve. And from a diabetes perspective, I think it is absolutely imperative that we have some information that relates to glucose and insulin use, and a way of recording the process that we've undertaken. And I think, therefore, the key part for most of us is to say, if we have an electronic patient record that we can record information into, that, if you like, is the key recording process that we need for virtual consultations. And of course, we have to have a person on the other end of the line who's motivated to make the consultation. And in fact, the publications that there have been around virtual consultations have made it fairly clear that actually, for people with diabetes, they often find virtual consultations much more appropriate than face-to-face ones around chronic disease management, because it allows them to have a little bit more control of where the conversation is going, because they can be motivated to that process. So realistically, what that means is, if you can access your EPR from home, as in fact I am able to through a virtualized network, this virtual consultation process can be undertaken completely from home and doesn't really need to be in a hospital environment or a clinic environment at all. So even individuals who are self-isolating themselves at home can actually still be undertaking useful support work in chronic disease management. So over the course of the last month, we've, I think, all become much more aware of video consulting tools. And I think the one that's been in most wide use around the UK from the perspective of NHS type appointments is this NHS Attend Anywhere screen, which is certainly what we use in my trust. And I've found it very effective, particularly because, having set it up on the machine in my office, it allows an individual at home to undertake that virtual on any device without any special preparation. That said, they do have to be able to click on a link and to set their machine up with their audio and video capabilities. And some people find that challenging. And a useful alternative that I often use as a backup to that is the clinic.co system, which is, again, another free system that literally just goes onto people's mobile phones. There are multiple other tools out there, from Zoom, Microsoft Teams, WhatsApp, Google Duo, FaceTime, etc., etc., etc. And I think the key piece for me that is helpful around virtual consulting is the idea of being able to share the screen. So if we're using data and showing data visually, to be able to share what we're looking at so that we can have that discussion. And I think, although sometimes we talk about virtual consultations as audio only consultations, from my perspective, the video makes a huge difference, both in terms of being able to perceive what is important to the person on the other end of the conversation, but also because if there is educational content that needs to be taken forward, realistically, that is an almost the same as face-to-face experience if you've got video to do it with. And certainly I've been through use of blood glucose meters with about 4 or 5 people on video consults, and then receive their uploads from home. So I know that that is something that can work. So moving on from the process of consultation, which will change a bit from centre to centre would be my guess. I think what's important to then say is, in a diabetes or chronic disease management consultation for diabetes, it's important to have information with which we will then consult. And I think just the fact that data has been collected doesn't mean that there's necessarily useful information for us to use. However, in order to generate useful information, some data must also have been collected. And I think that slight wordplay process is, however, a very important one. And it's this idea of structured monitoring data is what allows us to consult effectively rather than just random monitoring data. So realistically, although it's sadly something that still isn't undertaken as widely as it could be, the concept of uploading glucose fingerstick meters and using those as a data source for information creation in a consultation is a very strongly evidence-based intervention. And therefore, in my view anyway, should routinely be assessed in every clinic that we offer for diabetes. The challenge, of course, specific to virtual is that unless we do this in virtual, we really have got very little that's an evidence base to talk about. So I think this idea of having uploaded data for a virtual consultation makes it a particularly powerful tool. And of course, what that may well require us to do as healthcare professionals is something that we haven't tended to do previously, which is to try and support the individuals to undertake their own data collection beforehand and their own upload beforehand. And of course, that relies us to feel confident ourselves in how we do that process. And that's the next thing that I'd like to talk about a little bit once I've summarised. So I think for those of us that have been interested in doing virtual consultation and frustrated by the fact that it hasn't happened, this coronavirus pandemic is a great opportunity to try and push forward that process, both from the point of view of the immediate benefit it can have to individuals, keeping them away from the dangerous environment of a hospital at the moment, but also because it allows us to hopefully have those same setups that will remain there after the emergency period. Most of the offerings, in fairness, that are used for virtual consulting at the moment are completely free. So there is no cost to implement. And if you have an ICT team where you work, the idea of setting up virtual consulting will be one of their highest priorities. So there's lots of support to set that up if you don't feel particularly technically adept yourself. And I think what all of us as individuals then need to do is to say, how would I wish to practice in virtual? What in particular for my particular patient groups do I want to talk about? So my particular patient groups are people with type 1 diabetes, usually using technology as part of their management strategy, and people with more advanced renal disease who have a very different set. And so I have to think firsthand about which elements of virtual consulting I'm going to find useful for each of those two groups. And I think obviously the way in which we're consulting nowadays is, or at least for the duration of COVID-19, is very different because we're doing it only from a virtual perspective. So there I am, not usually sitting in a mask, but I'm sitting behind my hospital firewall and behind my physical walls of my hospital, aiming to connect using a computer to the individual with diabetes. The individual with diabetes has got a glucose meter, possibly a Libre, if they're lucky enough to have one of those. Most of those people will also have either a mobile phone or a PC. And so the idea that what we're trying to look at nowadays is to say, rather than physically uploading data into the computer that we're going to use to consult, and I'm just going to make everybody feel slightly sick. So you can see in the corner of my room, just about there, you can see we have a Diasend box that would sit and allow me directly to upload information into my PC with the person sitting in my room with me. But what we're now doing effectively is looking at a process where we take the data from the glucose device to either a phone or a PC at the person's home, where the person with diabetes will push it into a cloud. And there are many data clouds for diabetes information. And then what we want to be able to do is to view the data that is in that person's personal data cloud. There are a number of tools that will allow us to do this. And we can do that entirely by web viewing rather than by needing to push things directly through the firewall. And I think that's a very important process. Hospital firewalls are important and should remain there, but we can view data without interrupting the hospital firewall process. So there are many ways in which we can data share that will avoid hospital firewalls. So many smartphone-based apps, and I won't name them all. The two most commonly in use in the UK are probably MySugar and Diabetes M, both of which have now got purchase from meter manufacturers involved. The way those apps will tend to share data, however, is by the individual sending a PDF file to you as an email. Now, my own take on PDF files being sent to you to try and view is that they're better than having no information, because clearly they do give you validated data from the meter that is a true upload. However, they're potentially awkward to look at. And of course, the way that the person has used the meter may not exclude bias from that. Many of the more technical insulin delivery devices, such as insulin pumps and the CGM devices for monitoring, will have their own data clouds associated with them. So Medtronic for their pumps have CareLink. LibreView we know about for the Freestyle Libre. We know that the Dexcom device, for example, has the Clarity tool. But we also know that there are a number of broader tools, such as the My Life app, which is developed for Ipsomed pumps, but actually will take data from lots of other information as well, and has been made available free during the course of the coronavirus, and has a bolus advisor connected to it. The Tide Pool app, which is a freely available web-based service, which will download an increasing number of glucose reading and insulin delivering devices, but mostly with a US focus. It's a US developed and a US focused tool. And the one therefore that's in most common use in the UK is very much the Diasend app, or Diasend Gluco. And certainly in specialty care in the UK, that is the de facto standard. Over 90% of clinics in the UK have got access already to Diasend through a clinic account. And I think what's important to recognise, and one of the things I really wanted to push in this webinar, is the fact this is now much more widely available since COVID, and for free for most individuals to use. So that's the one I want to talk about in more detail than the others. So if one is going to use Diasend, the first question to ask yourself is, do I have a Diasend account, or does my place of work, perhaps more accurately, have a Diasend account? I say traditionally in the UK, many of the hospital diabetes clinics do, but actually very few at the moment of our primary care clinic services have a Diasend account. One of the things that's put people off is the fact that the Diasend accounts from a professional perspective have been subscription based until recently, but actually that is no longer the case. So Diasend accounts can be freely made available. But just having an account doesn't mean that we'll be able to do everything immediately. And we need to know from the patient perspective, what device are they using to connect? What time and date have they got set on their device? And do they have the appropriate cable and connector to allow that device to be uploaded? And do they have a PC or internet connection, or do they only have a mobile phone that they can work through? Because those will all make a difference to how we will undertake the upload process, or how we will support them to do the upload process. So I think for those of you listening who don't have a Diasend account for your clinic, or at least if you have one, you're unaware of it, now is a great time to make one because it's free. Slightly confusingly, to make a free Diasend account, you actually go to gluco.com rather than to Diasend. Diasend is for looking at the account. Gluco is where you go to make it. If you go to gluco.com, what you will see is this screen. And to get a free, what they're calling a remote care solution, you just click that second blue hyperlink on their opening screen. When you click that, you're directed to this form, which you fill in, send back, and you are then contacted by a member of the Diasend team in UK, who will send you a slightly more detailed form to make sure that when they're not duplicating an account that already exists in your workplace. And if they are, they'll tell you that. But then you will get your registration and clinic account set up within 24 hours. If you do that. So it's a really simple and straightforward process that you can set up very quickly from any internet linked machine. So in order to data share, the key thing that you need to know is your clinic ID code. In Diasend, the clinic ID code is 2 numbers separated by a hyphen from 5 further numbers. And that number is the number that patients need to know to share data with you. But it is also the number that you need to know to be able to offer that process. So if you know your patient's email address already, direct from within the web account in Diasend, you can invite them to join their data directly to you. If not, or you don't know their email address, what you can do is you can send out to them, and we often use this either in clinic or by the mail, a paper setup, and this happens to be our version of the paper setup, and all you can see that it's a very straightforward stepwise process for the person with diabetes to set themselves up at home, and we've just put a stamp on it with our clinic code attached to that stamp. when the person goes to DISEND, they have a very straightforward process. If they already have an account, they will simply hit the login button and put their details. Otherwise, they will hit the Create DISEND account and they will create an account which has got a data completing form that's very similar to the one for healthcare professionals. Having done that, the next step is to click a button which allows them to upload a series of device drivers to upload their meter data, and this is available for both Windows and Mac operating systems, although sadly not at the moment for Chrome operating systems, and I don't know if there are plans to introduce that. So Chromebooks aren't good for this at the moment. Having saved the installation file, which is very straightforward, they then run it, and when that's run, they then are able to upload their data from their meter. They start the uploader, they connect their meter, and we'll come back to how they connect their meter in a moment, because I think that's quite a key part of this process. And then they connect the cable to the device, to the computer first, and then to the device. And of course, the challenge historically has been this, that many different meters have got different cables that they require. Now, actually right now, this is much less of a problem than it has been, because as long as the individual knows which meter they have, pretty much all of these manufacturers will now provide free connector cables. All they need to do is ring the customer care line for any of the meter manufacturers and they will send out free connector cables. That said, in common with many other forms of electronic equipment at the moment, there are some standardization going forward. And there are a number of devices now that will connect using just a standard micro USB cable. So the sort that we might have to charge our e-reader, for example. And so we can see some of the Essentia meters, some of the Roche meters, some of the Nipro meters, some of the LifeScan meters, some of the Abbott meters will all directly connect on a standard cable. Some of the Essentia meters will actually have a USB standard connector as part of the meter itself. And we can see that micro USB is also what's used in a number of our pump uploads as well. So all of these devices can automatically be uploaded via a standard USB, micro USB, via the computer into DISEND, my apologies. And the slightly older standard was the so-called mini USB, and we can see that a number of the meters use mini USB. Again, all of these slides will be available at the end, so if you want to do a quick check which meter, which cable type process, all of these slides will be sent out to you, I think, either on your request or automatically. Again, that's perhaps something we can clarify at the end. So with that connection made, the upload is very straightforward, and then the individual just has to link the account using that code to the professional account. And then as a professional, you can see the whole list of individuals who have linked their data to your setup. Now, many people don't have PCs. Many people don't like cables. And we're moving into an era now where, of course, you no longer need a cable or a PC to make the upload. So those people who have a smartphone can, and this is available both in Android and in iPhone modalities, can upload the DISEND app, and effectively for a relatively limited number of meters at the moment, but the DISEND app can do everything that the phone would otherwise do. And again, you can share that information with your clinic using the clinic ID through the app, and these are the various display boards that they show. So, as I say, the number of devices that can connect directly to a smartphone are relatively smaller at the moment. So the WaveSense Jazz wireless meter, which is a titchy tiny meter, can do that using Bluetooth, as can the Nipro True Metrics Air. The Contour Next 1 can also do that, as can the Ario 2K, although the Ario 2K doesn't do it through Bluetooth, it's doing it through NFC, which is the same way that the new batch of Novo pens will be able to link once those are more widely available in the UK. Sorry, my mouse isn't wanting to behave. So the process of uploading through the app is actually, if anything, slightly simpler. Even you link the app to the device, click the upload button, it looks for the device, it finds the device, it asks to pair as with any Bluetooth device, and it then uploads in a matter of seconds. And of course, I'm talking predominantly today about SMBG devices because those are the ones that are more commonly out there. But of course, CGM devices almost all already have cloud data stored. And I think this is one of the things that many or most people using the Libre and their phone to scan it, perhaps unaware that their data is already in a cloud if they're using the phone to scan it. And that cloud can already be viewed at libreview.com. So if you as a healthcare professional know that you have someone using a mobile phone to scan a Libre, you can have one of two approaches to looking at their data. You can either say, look, we're doing this, can you log into your account and share your screen with me so I can see your data? Or you can do an exact parallel to the Diasend professional account and make a LibreView professional account, which is again a free process, and which you can then ask the patient again with a code number to link their data to. So exact parallel to what I've already described with Diasend. So there are some people who any form of data communication is too much data communication. Although, as I say, my intake is if they are able to see you on a video consultation, they're able to do the rest of it too. But I think that the very lowest tech is I will often send out to an individual a structured monitoring chart with an idea of this is when I think it would be sensible for you to do your checks. And I get them then to literally transcribe their data onto that, and then we literally look at that on the screen as we talk together. It's not my preferred method of communication, but it's better than no information, and I think it's an important way forward, and one of the reasons why video can be very helpful. So I think this physical process of setting up, I think, is one to jump into simply because historically we've all been very, not frightened necessarily, but loath to commit to this idea of lots of cables and things like that. The joy of the situation now is once people have set up, particularly with the Bluetooth and phone app based connections, they only need to do it once and their data is then always going to be automatically uploaded. So whenever you start a consultation, all you will then need to do is to log into their data, and there's no preparation required. It just goes straight in, and it's much quicker than anything else that we've done previously. So I think encouraging, if we're going to upload, to make sure that people keep an eye on the fact that the date and time on their devices is correctly set. Many people don't pay very much attention to that, but if you're uploading the information, it is important. I'm personally trying to encourage every patient that I see to look at the options for home uploading and home sharing of data, both for now when we're doing virtual consulting, but for the future as well. I think at the very least you should make sure you've got your own accounts available to do that, and then to practice with the information. And as you practice, I think what becomes clear is that the idea of using SMBG data in a structured fashion makes life much easier in this process. So what I'd like to know for the final 5-10 minutes is to talk about actually using that data. And I think that the key thing is that data doesn't come first in the consultation. Talk comes first. How are you, and the usual social niceties, but also trying to gauge what the person wants out of the consultation. Once that's done, particularly if that's a data related concern, then you should review the data and give yourself some time to do that. Explain to the person you're going to look at the data, and therefore you need to just think about it for a moment, because what you need to do is start making your own interpretation, which you're then going to use in the consultation when you're explaining and making plans to move ahead. So the structured monitoring sheets that I tend to use are this sort of process. The left hand shows the entire thing, which is an A4, which I send out to people. And I usually send it out with little dots in the boxes, depending on what we're aiming to do at the time. So the top profile that you can see on the green background here is, if you like, the monitoring that we tend to do when people come into hospital, pre-meals, pre-bed. And the reason we do that monitoring in hospital is because that is illness monitoring. So in fairness, relating to COVID and relating to people being ill with COVID, that's the monitoring that we're looking to try and achieve during illness. And so I think that's an important pattern to look at. But in more usual times, we're often looking at meal pairs to see the impact of individual meals, so before and after individual meals. It doesn't need to be done with every meal, but should be done with a scatter of meals over time. Or we can make plans that are specifically to do with areas of risk. This happens to be a plan looking at hypo risk for people on a twice daily mix, for example. Or if there's no idea particularly, we can just do a simple pattern plan, which just moves forward one slot each day. And you can do this on one test a day, one test every other day, or as in the case of this example, 2 tests a day. And I think when looking at the data when it comes forward, the important thing to know is that visually there are 2 ways to look at data. There is a way to look at data which is looking at it over time, the so-called longitudinal analysis, and the cross-sectional analysis, which gives you much more detail about the within-day change, which is often referred to as the standard day graph. And I like this slide, which is a rather old one of mine, for 2 reasons. One is it shows the clear difference between these 2. And in this particular version, you can see clearly this individual has relatively high fasting levels, but with relatively well-controlled levels during the day and often actually overcorrection around lunchtime. And this individual has a very consistent pattern over a number of weeks until the 2 weeks prior to this information being downloaded. And so we can see this is somebody who the last 2 weeks, whilst it will tell you what's gone in the last 2 weeks, has got very little relevance to the allow for. So I think looking at information on a structured evaluation is important. And I think this is the idea of looking at longitudinal before cross-sectional. Many forms of software will tend to look at cross-sectional first, like this. This data, which is old data, to look at cross-sectionally is very difficult, and it's confusing. And the reason it's confusing is because as you look at it longitudinally, it becomes clear that there's 2 very different data sets here. The first 2 weeks have got one glucose pattern, and the second 2 weeks have got a different glucose pattern. And if you mix those together, it's almost impossible to interpret. But when you separate them into the first 2 weeks and then the second 2 weeks, they've both then got a clear pattern into which you can then offer some advice. So there is some evidence around looking at structured data after the so-called structured testing program that was published back in 2011. And it's broadly a 3-step process. Once you've determined longitudinally that the data you're looking at is appropriate to make comments on, you first look for hypoglycemia, you second look for fasting hyperglycemia, and you third look for prandial hyperglycemia. And then in theory, what you will have, and this is one pattern of glucose testing. So this person has no obvious hypoglycemia, but looking for fasting hyperglycemia, that's clearly present. So this individual has a step management which would say, yep, we need to do something about fasting hyperglycemia. So if they're on a basal insulin, for example, they need an up-titrated basal insulin. The second pattern that we look at is saying, that, so the fasting now looks fine, but clearly there's a very significant rise that's happening after breakfast and again after the evening meal. So we've clearly got postprandial hyperglycemia, which has its own requirement for intervention. This is a more complex pattern which shows fasting levels are fine, postprandial at breakfast is fine, but by the time that they get to lunchtime, it's very high. Because they're high at lunchtime, they give a correction, and the correction does often produce hypoglycemia with resultant chaotic glucose levels afterwards. So this is an individual who is snacking mid-morning and either needs to not snack mid-morning or take a dose of insulin to match the snack so that they don't find themselves overcorrecting at lunchtime. Very logical processes and ways to take forward. So looking at CGM data, which is something I spend probably most of my life doing nowadays, it potentially can make this idea of pattern analysis much more straightforward. Although you need to be obviously aware that what you're looking at is, if you like, a likelihood sensitivity graph of a particular time of day, of a particular change. But of course, it's also important to recognize that CGM data doesn't always make things more straightforward, and it can sometimes make things more difficult to analyse, as in this scenario, which I would tend to refer to as chaos. In a small advert, I would mention at this point, I've been involved with a couple of other healthcare professionals from around the world in writing educational modules for CGM analysis. And for the duration of the COVID, and probably afterwards in reality as well, these are available as free downloads from the address that's on the bottom of this slide, agbclinical.org. And so they are normally certified, but the free downloads are just literally PowerPoint shows that you can look at on your own devices. But I think those will be useful, because I'm not going to be talking for purposes of time very much about CGM today. So I'd like to finish with a couple of examples of some of the commonest things that I've seen during this coronavirus epidemic. And so the first is a worried individual who is concerned that her sugar levels are high while she's in home on self-isolation, and she left a telephone message saying, "I'm worried that so many of my test results are running high in the 15 to 20 range." We had a very short conversation that asked her to upload her device, which actually she managed to do in a total of 10 minutes as an 84-year-old, which I was quite impressed with, I must say. And when she did that, we looked at the longitudinal data from her device, and we saw that pattern. And my immediate take that is clearly this is not an ideal glucose profile. However, neither is it particularly suggestive that in the last few weeks things are very different than they have been all the way through. So she is correct in that she certainly does have high sugar levels that are occurring all the way through the process, but it's not something that is particularly profound at the moment. And I suspect, as we're seeing a lot of people locked in at home, not with much to think about, who are worrying much more about their occasional high sugar levels than they have been in the past, compounded by the fact that when you look at her cross-sectional data for the last 2 weeks of that profile, what you see is this picture, which shows relatively well-controlled sugar levels at breakfast and lunchtime, but with rises that are happening through the course of the afternoon, probably related to boredom-related snacking. And the intervention, therefore, is almost certainly going to be related either to determining, does this lady have a requirement for some treatment around about lunchtime? Because remember, she's only at the moment on breakfast and evening meal insulin. Or is it because she's doing afternoon snacking, and simple afternoon snacking reductions or using snacks that are non-carbohydrate containing is the only intervention she needs? So this is, if you like, a profile that we see quite regularly during this crisis, and is one which is, from my perspective, or one that I would reassure someone on. I'm not a great believer in looking at numbers, but actually you can see the same thing for this sort of profile on numbers by the way that the logbook is identified. I've got two examples now of both people I consulted on the same day a couple of weeks ago, with remarkably similar circumstances actually. A 64-year-old retired carpenter who's on a premix twice daily and linagliptin. He's got CKD3B. He's had diabetes for about 14 years and has got airways disease. And he was discharged from hospital a few days before the virtual consultation. I was informed, and this was a virtual consultation about what should we do post-discharge. So he was admitted to hospital because of coronavirus respiratory symptoms, and was in hospital for about 10 days or so. And what's interesting is, if you looked at that profile and were trying to guess where he'd been ill, it's not immediately obvious, but it's actually this part of the profile is where he was ill. And if I show that in a bit more detail now, if I can, what we can see is he's not a great tester at the best of times. He's testing maybe 8-9 times a week, that's maybe a bit more than a couple of times a day perhaps. But what we can see is when he developed his first symptoms, the first response of his glucose levels is that they were a little bit higher than had been his previous norm. But as he became iller with the condition, and indeed he got admitted to hospital a week or so after his first symptoms, actually at that point, his sugar levels, if anything, were starting to drop. Now, this is a great example of, he continued to do some of his own monitoring, and we monitored him in hospital as well. But what then happened is, as he got iller still, his glucose control got ill, and he actually ended up on ICU. And obviously on ICU, he did stop doing his own monitoring. And on ICU, he was treated as if he didn't have diabetes because his sugar levels were in the 5 to 10 range. He came off ICU and started looking at his own sugar levels again, which had remained relatively low for his period on ICU. And at discharge home, they were still doing relatively well. But when I consulted with him a few days later, he was starting to see much higher sugar levels again. And what I think is important to note is that his original dose of insulin had been 30 units twice a day, which he'd cut down, or had been cut down when he was admitted to hospital. On ICU, he actually received no insulin. It was restarted at much lower doses at discharge, and then he'd crept it up himself a few days later. There's one other thing that I think is just a useful tip, which is if you look at the right-hand end of this graph, you can see that his figures almost form two lines. And this lower line that you can see relates to his fasting glucose levels, and the higher line relates to his levels during the day. So I think one of the things that we can clearly say at the moment is that he does not have an even insulin requirement across the day, which had been his historical use. And so even on longitudinal data, we can show that this is something that we can make changes to going forwards. And I think for me, this is important because it's a recognition that not everybody's sugar goes up with coronavirus. For some people, the anorexia that's produced by it actually creates them to go down. By contrast, this individual with very similar background, actually, not quite as bad renal disease, he's 3A, a little bit younger. He's on basal insulin and dulaglutide and hasn't had diabetes quite so long. He also had coronavirus, or at least we're assuming it was coronavirus because he didn't get tested because he stayed at home. And he contacted me on the same day, or we contacted each other on the same day, once he was recuperative at home. And by contrast, you can see this gentleman for many weeks and months going into his illness had had really good glucose control on his combination of basal insulin and dulaglutide. He became ill at about this point, and I think this highlights a couple of issues really. The first is that he became ill and stopped monitoring, which obviously suggests that his following of sick day rules is perhaps not quite as good as it should have been. And once he restarted, but when he was feeling a little bit better, his sugars were much higher. And as I say, we consulted together right at the end of this graph, and actually he just sat with his sugar levels being much higher at the end of the graph, having effectively, when he was ill, stopped taking his dulaglutide. So I think his last dulaglutide dose was around about the 8th of March. And so this jump was all because he hadn't restarted and hadn't thought to then restart it himself again afterwards. So very dramatic. So I'm hoping that the restarting afterwards will be what affects it, although we haven't had a chance to take that forward again yet. So as my summary at the end of this, I'd say having downloaded information can be an absolute lifesaver from the perspective of making virtual consultations. And the key messages are to make sure you view data both longitudinally first as a trend view to determine whether something that's happening is something that's happening new or is something that always happens, and only then to look at the cross-sectional. The glucose changes we see with coronavirus can go in either direction, up or down. And I think my hope anyway is that once if we undertake this process during the coronavirus outbreak, we will be much better positioned to maintain this idea of closer virtual support ongoing thereafterwards. So on that, I'd like to stop. Thank you for your attention, those of you that have remained attentive to it. We will take some of your questions. I think,
shall we start with, is anyone considering doing drive-through HB1A1C with a clinic analyzer?
So I think that's possible. From my perspective, to do with acute illness, however, it has no value, because what we see is with A1C is a 3-month value. It doesn't help us to make changes. So the A1C, you might say, is a process of is everything in the right place at the moment? And I think for the purposes of where we are right now, glucose-related data needs to come from glucose monitoring, not from A1Cs. I see A1C as much more of a stand back from it process, because all it ever does is wave a flag to say everything looks like it's probably okay, or actually no, it's not okay, and it doesn't tell you what to do about it. So I think in this unusual circumstance when we're all concerned about how to, I don't think getting A1Cs done during the coronavirus is important. I think making sure that people know what's going on with their glucose levels is.
Okay, thank you. Another question is, are all the virtual tools you've mentioned secure to share confidential data?
So are all the meters, did you say, or all the systems?
All the virtual tools.
The virtuals. So realistically, what we would say is, in order for these cloud-based systems to get accepted and used in the EU, they all have to comply with the EU data rules. From the perspective of hospital-based use, we have our own data protection officers in hospitals. The thing that I find particularly useful in this context is that the data doesn't sit in the hospitals. The hospital or the healthcare or the surgery doesn't hold the data. The data is in an individual cloud for the person. They've created their own data store, and all they've been doing is allowing us permission to look at it. There is no data held within it. So from that perspective, certainly Diasend is data secure and has been EU licensed for at least 2 decades now. LibreView likewise has the data licensing, as do the Dexcom Clarity, as do CareLink and things like that. So the vast majority of them are. The apps on phones may be less secure, particularly those that are just sending data up as a PDF, because the intention with those apps is that they're really just being used by the individual themselves, and that the add-on for sharing is literally just a last minute, oh, you can send an email if you like. So for those apps that send PDFs, the security is no more than it would be on a normal email. So you could argue that's the case, but we can't demand those. Those are patients sending them to us anyway. So that's their choice to do or not, as they choose to see fit.
That's great. Next one, are there any patients or situations in which you think virtual consultation does not help?
So I think there are circumstances which you would imagine you can't fix during a virtual consultation. However, actually, I think the virtual consultation does always help, because if nothing else, it allows you to triage, is this somebody I actually need to bring and see face to face? And I say, I think a lot of that is about the visual, and I think video is really helpful. Is this person ill online, which is much easier to pick up on video than it is when you're on the phone to somebody. People who are actually very ill don't always sound that ill on the phone, whereas on a video you pick that up very quickly. And so I think the video consultation is always helpful, but you can't always fix everything over a video consultation. But I'm increasingly impressed with actually how much you can help with in a video consultation. So if you'd asked me, I wouldn't have said that you could train someone to use a glucose meter online, but you absolutely can.
Perfect. So another one. If English is not the first language, are there any apps to help you use during a virtual consultation?
So that is a good and difficult question. So the answer is some of the apps have other language options for them. I'm not aware that there is any direct, I mean, there are obviously a number of apps that will allow translation services to happen via the apps, and most hospital and GP services will have access to one or all of those, or if nothing else, we can use Google Translate, which I have to say is often hilarious, but is better than nothing in some circumstances. But actually, there are very few of the apps that are deliberately bilingual, although some of the, and I've not been talking really in this seminar about the self-management apps, you know, the sort of My Diabetes, My Way type apps, but a lot of those do have alternative language options on them. So I think a lot of those, what would you call them, coaching type apps do have alternative language options, although generally most of the data sharing ones are less likely to have that because it's the numbers that they're tending to share.
Okay, that's great. What about recording consultations? What's your view on this?
So yeah, there's been a lot about that, hasn't there, around the idea that people are worried that consultations might be being recorded on secondhand whilst you're doing the video. To be honest, I don't think that matters, because they could be recording your consultation in the clinic for all you know. you know, that we know that that's happened, and we know that that will happen. And I think the key thing, therefore, in Consultations is if you only say something which is an evidence-based statement, which is why having data uploads is so important, you'll never say anything which is likely to be misconstrued. It's when somebody tells you, oh, my sugars have all been a bit high, a bit like my 80, and I'll say, oh, do you know what you'd better do? You'd better increase your insulin then, because I actually haven't looked at the data. And if I'd said that to my 84-year-old lady who is, if you like, the worried well person in the example, all I would do is produce morning hypoglycemia, which would probably be much more hazardous for her. And then I would quite, in my view, appropriately be being questioned about, am I being, because I'd given advice without there being any evidence base to base that advice on.
Okay. That's really helpful. This is a question from Ireland. Do you know if Dyson, the free version, is available in Ireland?
It's available all over the world. So you go to gluco.com, you click that link, and they will send you the form to fill in. And as I say, I spoke to them a week or so ago. Their guarantee is anybody that does that, they will have a working account within a week.
Okay, that's great. Let's have a... Some pumps download on Diasend give better information than others. With Insight, you get no reference to settings, ICR and IFSF. Do you have any idea why, and do you know how we can retrieve this info?
So that's a detailed question. So actually Insight does give you those things, but you have to look at them in a place that you wouldn't imagine. So the obvious place that you would look for those pieces of information would be in insulin. But for reasons that are specific, I believe, to the way that the data is transferred from Insight, you actually look for it in the meter settings, not in the insulin settings part, and it gives you all of those information. And I think historically that's because all of their ratios were set up on their meter, so they call them meter settings, not insulin settings. But actually they are all available. And actually, from my perspective, the nice thing about using Diasend to upload pumps is actually it's the commonality of the information, because you see the information, whichever pump it is, being offered to you in the same format. And I think that's a really powerful tool for a healthcare professional, actually, because we can get good at using one tool.
Okay, that's really helpful. You mentioned a number of data sharing tools. Is there one which is better or best? And is there one meter which is better or best?
So which two? So I guess I've sort of answered that by the presentation in ways, which is, I think within the UK, the de facto standard is Diasend. So does that mean it does the job better than others? Well, possibly not, although I think it does a very good job. It's certainly got the widest range of meters that you can download into it. So almost all areas nowadays, because of reasons of cost, will have some form of meter formulary saying, do we like these meters or don't we like these meters? And where it has been thought about on a slightly deeper level than just cost, certainly the connectivity will be one of the issues. So for example, locally down on the south coast, no meter gets on our formulary unless it is Diasend compatible. And I think that's probably common around a lot of the UK, because there's no point having information if you can't see it.
We've had very good experiences of Tide Pool in the paediatric population, especially the fact that it pulls the information from multiple devices into one easily viewable system, which seems superior to other systems. What are your thoughts?
So I think if you get on well with Tide Pool, use Tide Pool. I think my own experience with it has been slightly less good. I think one of the things historically that I have liked about Diasend is the ability to do a physical download in the hospital circumstance, whereas with Tide Pool, there isn't a physical downloader. With Tide Pool, it's always a computer-based download. And certainly my belief is that hospital firewalls are important things, and therefore we shouldn't be trying to download devices through firewalls. I think it's fine to look at websites, but if it requires a computer to send the data, that should be coming not from behind your firewall, in my view. That should be coming from the person's home. So it may well be that this circumstance where people get this principle of, yes, I want to download from home in advance of a clinic so I don't waste time in a clinic, may help the use of Tidepool. And certainly, yes, it is free. I think a lot of it will depend what devices you use, because certainly it's certainly true that the Tidepool repertoire of devices has got much wider over the course of the last year or two. And certainly, I think where Tidepool is particularly good is in the pump and CGM linking field. But in terms of the general adult population, I think DISN probably is still my preferred tool at the moment. Although, will that change over time? Who knows?
Okay, we've probably got time for 2 more questions. So, stopping metformin in suspected or confirmed COVID-19 cases. What are your thoughts?
Okay, so I think realistically, so with metformin Sickday rule, and I guess this is a sort of a Sickday rules question, really. And actually, if I can for a moment, there's a couple of additional slides, if I share my screen again, that I could, assuming I can find it. Here we are. Share. There we go. So I think there's some useful stuff, both about drugs and about general principles. So this is a table from a paper written by Sue Down, who's a consultant diabetes nurse, I'm sure widely known amongst the audience, working in Somerset from a year or two back now. And the right-hand table of this is about specifically what drugs do I think about during illness. And the left-hand table is one about what do I think about in terms of specific diabetes management things. And I think that for most individuals with illness, if there's a risk of dehydration through the illness or a risk of severe hypotension because of the illness, then we recommend that metformin is stopped. Pretty much we're recommending SGLT2 inhibitors are stopped in all individuals who get admitted to hospital. And actually things like antihypertensives and non-steroidals, which are often being used at that time, we know also during acute illness may not be their best friend. So we generally will look fairly critically at stopping a lot of these. And then in terms of Sickday rule resources, most of you, I suspect, will be aware that Trend have updated their Sickday rules documents since the coronavirus. And so again, this slide, which again will be linked, has got a bit.ly link to the type 1 and the type 2 Trend resources on the downloaded ones.
Yeah, absolutely. So last question, if that's okay. Someone has said, I would love to give this a go and practice, but as the only nurse in the surgery, my concern would be it would take me a really long time to get to grips with it from download to interpretation. Is there any support from the hospital team?
So, I mean, I guess the answer is I would like to answer on behalf of the hospital team. I don't know which hospital team we're talking about unless you know where it's come from. I think most hospital teams would want to support a community team in doing that. And of course, the other element about it is to say if an individual has downloaded their own data, they can choose to share it with more than one team. So they can choose to share it with both their GP surgery and their local hospital team if they choose to do it. So actually you can almost, I mean, I would say talk to your local specialty care deliverers. If they're using, the obvious thing to do is to try and use the same system that they're using, so that you can have that process. Because I think nothing trains you up and builds your confidence more like than working with someone doing it. And I think, I think for single-handed, for me, virtual consulting shouldn't just be about patient to healthcare professional. It should be about healthcare professional to healthcare professional as a supportive process. And I think, from that perspective, having appropriate information always helps that process. So I'd like to say the answer is yes, your specialty team will help. Not knowing which your specialty team is or where you're from, I wouldn't want to do so quite so confidently.
Okay, well, that is all we've got time for in regards to questions for now. I'd just like to say a big thank you, Iain. I found that really helpful and I hope everyone else did as well. So again, on behalf of SBK Healthcare, I would like to thank Iain for delivering this fantastic webinar, and also to Agamatrix for supporting it. And finally, we want to say a huge thank you from the bottom of our hearts for all the hard work and dedication that you are putting in. Thank you very much, and goodbye.
Thank you, goodbye.
If you enjoyed this video, please do give it a like using the thumbs up button, and share your feedback in the comment section below. In order to ensure that we continue making and uploading this content, please do subscribe as well. If you would be interested in attending a live webinar, please visit our website for more information. The link to our website will be included in the description box for this video. And finally, please ensure that your notification bell is switched on so that you will be the first to hear when we upload a new video to our channel. Thank you very much for watching.